Okay. All right, so I'm Dr. Young Parrott, and this morning we're gonna be going through the lecture entitled The Child with Red Urine. Please feel free to stop me if you have any questions or concerns. All right, so the objectives of this talk is to 1, define hematuria, 2, to differentiate causes of red urine versus hematuria, and 3, to review the causes of hematuria with specific attention to acute glomerulonephritis, post-strep GN, and to review the management of post-strep GN. So we're going to start with a little case, but in the interest of time, I may actually move forward and then we'll come back to the case later on. So you can have this case in mind. So you have an 8-year-old female presenting to the emergency room with a 2-day history of blood in the urine and swelling to the face on the morning of presentation. What additional information would you like to elicit from the history? And 2, how would you investigate this patient? So I'm going to open the floor for you guys to give me a few comments on what additional information you'd want to elicit from this particular history. Don't all shout at once. Okay, I'm seeing the quantity of blood. Excellent. Anything else?
Has the child been sick recently or been around anyone that's been sick?
Excellent. That's very important. And why are you asking those particular questions?
Could be from a viral illness that could help.
Excellent. Right? So any viral illness like adenoviral infection sometimes can cause a cystitis. And yes, for sure, you can get blood in the urine. I see a previous history of hematuria, very important. Why would we want to know about a previous history of hematuria? Anybody? Right, so you're thinking about it could be related to like a stone. Excellent. And also remember that you may have recurrent episodes of hematuria that may be as a result of a pathology or condition called IgA nephropathy, right? So they may have recurrent episodes that may be related to upper respiratory tract infections or febrile illness, and then they will have hematuria. So that is also very important. Anything else?
History of a UTI.
Excellent. Right. So you want to know if there's a history of a urinary tract infection, because remember, urinary tract infections can actually present with hematuria. So that's also very important. So once you have a patient presenting with hematuria, you also want to rule out a urinary tract infection. A history of prior urethral instrumentation, yes, that's also important, because if the patient recently had a surgery and it was a day case and they were sent home, then they can actually represent with blood in the urine. All right, excellent. So what basic investigation would you want on a patient who presents with hematuria? Basic, very, very basic.
Urine dipstick?
Yes, you need a urine dipstick. And on the urine dipstick, that can give you a lot of information whether or not there is just hematuria by itself, whether it's isolated hematuria, or whether or not there is coexistent proteinuria, or are there leukocytes and nitrites that may be in keeping with a urinary tract infection. It also gives you information on the specific gravity and the pH of the urine as well. And then once you have a urine dipstick, then you want to go on to do what investigation with the urine?
Urine microscopy.
Excellent. So you're gonna look at the urine microscopy. And then that will give you a lot of information as to whether or not this is true hematuria or not. Excellent. So we now have a background for our presentation. So let's move on. And we're going to move on here, and we'll come back to this. So hematuria is really greater than 5 red blood cell per high power field on microscopy of the sediment of a freshly voided centrifuge urine at 1500 to 3000 RPM for 5 minutes. Now, hematuria can be benign or pathological, as we will explore a little bit later on. And when we think about pathological causes of hematuria, that would include like stones, malignancies, cancers, or glomerular diseases like your acute glomerulonephritis. It may be visible or microscopic. So visible meaning gross, or microscopic meaning that you only pick it up, like on a dipstick. It can be transient in the cases like you may have vigorous exercises and then you may have a little bit of blood in the urine, or it can be persistent. However, of note, persistent hematuria should always be investigated. Or you can categorize hematuria as renal causes, non-renal causes, or it may be due to systemic diseases such as sickle cell. Now, in regards to the approach to the patient with the red or brown urine, so we talked a little bit about centrifuging the urine. So if after centrifuging, the sediment is red, then that is likely hematuria. However, if after you centrifuge the urine and the supernatant is red, right, and the sediment is clear, and your dipstick was positive for heme, then you're now thinking about whether this is due to myoglobin or hemoglobin. Remember, not all red urine is hematuria. So if your dipstick is positive for heme, you think about myoglobin or hemoglobin. And depending on the plasma color, if it is red, it's likely hemoglobinuria, or if it's clear, then it's myoglobinuria. Now, if your dipstick is negative, right, then you're thinking about other things that can actually cause other stains. So like children who have a lot of beetroots, right, other medications, and porphyria or other causes of red urine as well. Now, this slide is just showing different causes of hematuria by age and duration, right? So if you look on the under 10 group, or somewhere between 15 and 20, somewhere between the below the 20 age group, if you look about transient causes, then you have a lot of unexplained transient causes of hematuria. But more commonly, a urinary tract infection can explain the cause of hematuria in this particular age group. Smaller percentage as they get older for exercise and trauma. And you may also see sickle cell disease or hemoglobinopathies manifesting here. And then at the bottom, for persistent causes, then you think about your glomerular causes, like your acute glomerulonephritis. Now, this is a slide. I liked it, but not all of the causes are actually related to the pediatric population. Majority of them are, however. So if you look at renal causes, right, your angiomyolipomas, which sometimes we get in the pediatric population, can account for hematuria. And we don't generally get, in terms of the malignant masses, we may get Wilms tumors or your neuroblastomas. And for your glomerular causes, you have your IgAs, your Alport. For polycystic kidney disease, a pyelonephritis comes in pretty high, and then other causes are like hydronephrosis, hypercalciuria, hyperuricosurial, any renal vein thrombosis. And in the case of sickle cell disease, a papillary necrosis can actually cause hematuria. Just to mention again, there are mimics of hematuria. So in a female who is of age, who may be going to puberty, then and they may have started their menses, then that also could actually confound what you pick up in your urine. In the ureter, we mentioned stones, strictures, or other common causes. And if you look at the upper and lower urinary tract system, any infections along here can cause hematuria, tuberculosis can cause it, and schistosomiasis. Strange enough, I actually had one patient who had presented with hematuria, persistent hematuria, and we did a lot of investigations and they all came back negative. And then we actually sent the urine and we tested for this organism, and it actually came back positive for the organism. So we still have to think about a lot of things. Don't forget that you have your bleeding diathesis that can actually present with hematuria as well, so you have to think about it. The cystitis I mentioned earlier, and this bottom section is not related to the pediatric population at all. So in terms of historical clues, what you want to ask, is there a history of dysuria, frequency, flank or abdominal pain that may clue you into like a urinary tract infection or a cystitis? Sometimes poor urinary stream or hesitancy can be in keeping with avoiding dysfunction. Is there a history of upper respiratory tract infection that may be in keeping with IG as I mentioned before, or if there's a preceding history of an upper respiratory tract infection, a tonsillitis, a pharyngitis, like a 10 to 2 weeks period, maybe in keeping with a post-strep glomerulonephritis. Is there a skin rash? Is it purpuric in keeping with Henoch, Schonlein purpura? Or is this an impetiginous rash that has been there for like a 3-week period and now the child is presenting with hematuria for you to think about post-strep glomerulonephritis as well? Is there a flank to groin pain that may be in keeping with a stone, vigorous exercise I mentioned before, and of course you have to rule out a bleeding disorder, or if you're on anticoagulation therapy, when they actually presents with hematuria. And for bleeding disorder or anticoagulation therapy, more than likely they'll present with gross hematuria versus microscopic hematuria. Past medical history we mentioned, UTI, whether they have sickle cell disease or the trait, if they have a coagulopathy, like hemophilia A or B, A or B, where this is cyclic hematuria. Medications, so don't forget that medications can cause a nephritis. And in so keeping, thinking about your NSAIDs as well, they can cause a nephritis. So you want to ask about that in the history as well. Family history, so if there's no personal history, you want to ask about a family history of sickle cell disease, hereditary nephritis, polycystic kidney disease, or a family history of deafness that may clue into Alport's. So what are you looking for on examination? So you want to look at your growth parameters. In particular, you also want to look at the weight, because remember sometimes sometimes the children who may present with an acute glomerulonephritis, they may actually have increase in their weight, and that's as a result of increased fluid retention that may cause an increase in their weight. Also, regards to their growth parameters, some of your children may actually be failing to thrive, and that may clue into the fact that they may have a chronic kidney disease. such as your obstructive uropathy, your reflux nephropathy, and those may actually be contributing to why the child is failing to thrive. So those are important parameters. Whether the child is febrile at this point in time is also important, and your blood pressure is also very important because patients who may have acute glomerulonephritis may actually be hypertensive. So it's important for you to document their blood pressure. You may find edema, and the edema may be periorbital, so that's the first place that is easily noticed. In the periorbital area, you may have facial edema, and then you may see the dependent edema with regards to your pedal edema as well. So these are things that you do want to look for and check for as well. Okay, so with regards to the growth parameters, so I was saying that one, your weight can be very important because sometimes when your patients may have an acute glomerulonephritis, they may actually have an increase in their weight, and that may be as a result of fluid retention, right? The other thing I mentioned with regards to the growth parameters is that your child can be failing to thrive. So when you plot the child, you may realize that all the parameters, well, the weight may be less than the third, the weight for height may be less than 85%. And if you have their books, you may realize that they have crossed 2 percentiles within a 3 to 6 month period. So regards to the renal aspects, then you'll be thinking about whether or not this child may have a chronic kidney disease, like in particular obstructive uropathy or a reflux nephropathy. Is that clear? Okay, great. So moving on to skin rash, mentioned the purpura before and impetigo, so you'll be looking for those. And in terms of the abdomen, you'll be examining for masses, benign and non-benign masses. So a Wilms tumor, neuroblastoma can present with generally microscopic hematuria, or if they have signs in keeping with a pyelonephritis or any form of cystitis. So those are the things that you'd be examining for. And of course, you want to do a genital exam because you want to look to see if there's any evidence of trauma, irritation, abrasion, or any other pathology that could actually contribute to the passage of blood in the urine. So now this is a little schematic diagram that can help you to determine how you proceed in terms of evaluating a child who has gross or symptomatic microscopic hematuria. So you want to elicit from your history, is there a history of trauma? If that is the case, then you want a CT of your abdomen and pelvis, because you need to be able to delineate where the damage is. If there is no history of trauma and there are signs and symptoms of a urinary tract infection, you move on to do your urine culture and you treat appropriately, right? If there is if there are no signs of a urinary tract infection and you realize that there are signs and symptoms of perineal or meatus irritation, then you really just reassure supportive care, loss of fluids. And if in the case there is no such symptoms, but you may pick up that there may be signs and symptoms of renal or urethral stones, as we mentioned, the flanctal line pain that they may have, or they may actually have chills and raggles, fever, they may be nauseous in ovary cases, then you move on to imaging, which would be like a renal ultrasound. And more specific for stones is actually your CT. If there are signs and symptoms of a glomerular cause, so in this case, your urinalysis and microscopy will actually help you. So if you're seeing proteinuria in conjunction with hematuria, and when you do your microscopy, you're now seeing red cell casts, which sometimes can eventually become granular casts, then you're now thinking about glomerular cause. So if you think about a glomerular cause, then that's enough reason to refer to your pediatric nephrologist, who may then go on to do additional investigations, may check the renal function, they may look at the complete blood count, they may also do a C3, C4, looking for autoimmune immune cause. They'll check the albumin, and they may also decide to check the ASOT or the ASTO, or they may do any form of streptozyme test. Now, if there's no obvious signs or symptoms of a glomerular cause, then and there's no obvious cause on history, physical or urinalysis. So all the patient produces is just blood in the urine, right? You confirm that this is true hematuria. But on examination, there's nothing to find. On history, there may not be anything, because sometimes patients may just have maybe referred to us, the pediatric nephrologist, for hematuria, and that may be just picked up on a routine school medical, right? And they may not be having any other symptoms. So tests to consider in that time would be like a urine culture. You can then test for hypercalciuria. So you do your calcium to creatinine ratio. And then you may actually want to find out if this is something that runs in the family, like a hereditary nephritis. So you want to test the parents to see if they also have hematuria. But also bear in mind that there are other confounding medical conditions that can actually affect the parents having hematuria. So if they're on HIV medications, if they have coexisting lupus nephritis, then they may actually have hematuria. So you also have to be conscious of that. You want to do your HB electrophoresis, so you're looking for the sickle cell trait, which may not necessarily just be AS, but you may have other forms of sickle cell trait, and your renal ultrasound. If your diagnosis is apparent, then you go ahead and treat. If it's not apparent, then you may move on to do additional investigations. So when a brief study was done in the pediatric population at the University Hospital of the West Indies, in descending order, AGN was the most common cause of hematuria, followed by a urinary tract infection, then hypercalciuria, trauma, sickle hemoglobinopathy, and query IG, because sometimes it's very difficult to prove that particular diagnosis. Another study that was done by the urologist, a 10-year review, they found that urethral irritation or trauma accounted for 15%, UTI was 14%, and your vesicular-ureteral reflux, valves obstruction was another 13%, stones was 5%, and malignancy was 1%. And then there was another retrospective study, this time looking for asymptomatic gross hematuria. 36% of the time they found no identifiable cause. 16% was IgA nephropathy, post-strep was 7%, and you have other causes accounting for a small percentage. So your investigations will depend on your etiology, right? So as we mentioned, we started out with our urinalysis and microscopy, then we move on to a urine culture. Depending on what you're thinking, depending on what your history suggests, then you may move on to other investigations. If there's significant proteinuria, you may want to do a spot protein to creatinine ratio. Hypercalciuria, you may want to do a uric acid to creatinine. And depending on whether or not there's a history of trauma, a CT abdomen, and you may also want to look for evidence of obstruction in your ultrasound. So once again, if your evaluations are negative and persistent, you refer to the nephrologist. Now, just quickly looking at post-strep GN. So this is as we mentioned, one of the more common renal conditions that present with hematuria in our population. I think we maybe can look at it again to see if it still remains the same. But it's one of the most common cause of acute nephritis worldwide. It is more prominent in the developing world, and it is usually in the 5 to 12 year age group, or you may also be seen in the older age group above 60. And usually it's caused by glomerular immune complex disease induced by specific nephrogenic strains of group A beta hemolytic strep. Now, there are two nephrogenic antigens, one that is associated with plasmin receptor and the other with the pyrogenic exotoxin B. Now, your clinical findings usually include gross hematuria with edema and hypertension. Some cases they can be asymptomatic, or they may just present with microscopic hematuria to the full-blown acute nephrotic syndrome. And the full-blown would then include your gross hematuria, your proteinuria, edema, hypertension, and they may actually have azotemia or some acute kidney injury. So in terms of laboratory findings, you may realize that you may have dysmorphic red blood cells, you may have red cell cast, varying degrees of proteinuria, pyuria, and your ASTA may be positive and your C3 low. So the management is really non-specific and is mainly supportive. So you want to restrict fluids. And in terms of restricting fluids, we usually restrict fluids to 3/4 maintenance, and we continue 3/4 maintenance until we know what the urine output is. Once we know what the urine output is, then we give them fluids at insensible plus their urine output, right? However, if over time and their renal function recovers and their insensible plus urine output is greater than their maintenance, then we actually may revert to giving them their maintenance. Sodium restriction is also very important because if you think about it, water is going to accompany salt. So you really don't want to increase the amount of salt in their diet because it's going to cause fluid retention and worsen their hypertension in cases where they're very hypertensive. In some cases, you may have to put diuretic therapy on board to kind of help drive the urine output, and also to, if there's significant evidence of fluid overload, you may also want to try to assist with diuresis to reduce the complications from your fluid overload. Antibiotic therapy, if there's any obvious infection at the time, you may want to treat a particular infection. In other cases, you may want to give a start dose of Panadol. In some cases, they may have very bad acute kidney injury, and in a few cases, they may need dialysis. And in most cases, they're usually complete recovery within a 2 to 4 week period, and you continue to follow them up. So one of the particular important investigation that you don't do for a patient who has post-strep GN is your C3. And usually what happens is that your C3 will be low, but you'd expect that your C3 will normalize within a 6 to 8 week period. If your C3 remains low after the 6 to 8 week period, then you have to think about other causes of this presentation. So you think about your membranoproliferative glomerulonephritis, you think about lupus, sometimes your shunt nephritis can present with a low C3. But in general, those are the more common causes. So this is really, for those of you who are interested in pathology, is if you look to your right, so your post-strep GN comes under your immune complex GN, and if the C3 is low, right, then here you think about, so what the C3 sometimes is usually low because you may have deposition of the C3 complexes within the kidney itself. If you see a low C3, post-strep GN, MPGN, SLE, and a shunt nephritis. If your C3 is normal, you have a similar stain, then you think about your IgA nephropathy and your HSP nephritis. Any questions? All right, so with respect to the fluid management for post-strep, so usually we fluid restrict them. And we start with 3/4 of their maintenance until we know what their urine output is. Once we know what their urine output is, then we actually give them insensible plus urine output. However, over time period, once the kidney recovers, then you may realize that your insensible plus urine output is actually greater than your maintenance. And in that case, you may opt to go with maintenance instead. Is that clear now? Okay. Any other questions? So this is supposed to be basic and is really for you to start thinking about what the causes of red urine is, and for you to realize that not all red urine is true hematuria, and for you to start thinking about how you would actually try to define whether this is true hematuria or not. More importantly, if it is that your hematuria persists, then you should refer to your pediatric nephrologist. And then also for you to be familiar with the management of one of the more common glomerulonephritis that we actually see in our population. Was it very clear, too simple?
It was a good lecture, Doc.
Okay. All right, great. So now I'm right back here. Now there's a history of, so if you remember the case, you have an 8-year-old who presents with a 2-day history of blood in the urine and swelling to the face on the morning of presentation. We went a little bit through A and B. And so now I'm saying there's a history of sore throat 10 days ago that resolved on its own. What would be your differential diagnosis? Right, so you're thinking about post-strep GN. Anything else? So I actually like the terminology as a post-infectious glomerulonephritis. I like that particular terminology. And then I'd be thinking more commonly whether or not this is actually post-strep GN. And I will say that because when I go back, you realize that there are a lot of infections that can actually present with glomerulonephritis, right? So you have the bacterial causes that we're more commonly used to with your group A strep, but you have other infections and other viral infections. So until you have your investigations, you think about your broad category would be like a post-infectious glomerulonephritis, then you'll be thinking that it's probably likely a post-strep GN. Okay. All right. Any other questions, concerns? All right. Thank you very much. I'm sorry we weren't able to delve a little bit more into the case due to the time constraints, but I do hope that this kind of refreshed your memory on your approach to a child with red urine.
Thank you, Doc.
You're welcome. All right, enjoy the rest of your day. I guess I have to leave the session because I can't stop the recording.
Oh, yes, I think Dr. Bailey would have to come back and stop the recording.
Okay, thank you. Bye, everyone.
Good morning, class. This is Dr. Crossdale. There's been a problem with the UE site. I don't know if you're hearing me. Are you hearing me?
Yes, Doc.
Yes, Doc.
Yes, I just had to call Dr. Bailey. We're having problems signing in, so she just had to send another link. So I have to apologize for the delay. I was on another site for around 10 minutes. Well, not quite 10 minutes when I realized nobody was there. When I called her, she said there's a problem with the site. So I just got another link, so I'm just joining you guys now. So I'm just going to, since you're running late, I downloaded the presentation. Let me just try and find it. Where did it go? Okay. I'm going to share it to the class, and hopefully let me know if you're seeing it. Why is it not sharing? I don't know what's wrong, but it's not allowing me to share the file. I'm going to download it again and try. Not working out so well this morning for us, class. I don't know what's going on at this site. What is going on? There's another one that is on that needs to be, that's the problem. There's a red urine that is on. I don't know if you've seen that file. It is blocking mine. I don't know how to get rid of it. Yes, but she didn't delete it, so it's blocking my file from. I'm going to try and remove it. That's why I just realized that's why mine is not coming up, because her file is there. Yeah, I can't. You're right. I can't remove it from my end. Oh, boy. Oh yeah, the icon for stop recording. I'm looking for that. Oh, Dr. Bailey, then I'll have to call her because she said she had problems this morning. I got rid of her file, so I'll try and put up mine now. Thanks for that information about that icon. Let me see if it didn't now accept my file. It's still loading her file. It's not, although I say stop sharing, it's not allowing me to. It's very frustrating. All right, I'll call Dr. Bailey, see if she could fix this problem. So it's still bringing up Dr. Pierce's file. Unless I delete it, I don't want to do that. We tried the other classroom, it didn't work. That's why I'm now here, because we're having problems with the other classroom. I'm trying to delete that file with the red urine, see if that will help. If it will get rid of it if I delete it. I'm going to remove her file and then try and see if that would help. It's not even removing. Trying to remove it and it's not going at all. All right, guys, I have to call Dr. Bailey, see if she could get some help because it's not working. And this is a lecture I've presented many times, so I'm not sure why there's a problem. Sure. I'm not sure what the problem is, to be honest, why we're having this. We might have to, I'll talk to Dr. Bailey to try and see if somebody could come and see what the problem is. So if you just have the patience to wait. I'm not sure why it's not loading. It's not loading, Laura. It's not. We're having a problem, Kim. Class, it's not going to happen today. I've spoken to the technician. They have suggested going through Chrome. I've gone through Chrome and it's not loading. I really don't know what the problem is. And they don't know what the problem is either. So we're gonna have to reschedule because I can't teach without the lecture. And it's not allowing me to get on. I just have to call Dr. Bailey. It's just not allowing me to get on at all.
Okay, Doc. We have a session this evening or this afternoon for the examination of the cardiovascular system. At what time?
Yes. Dr. Bailey said I should find what is your schedule like today?
Well, we're supposed to come in at 2 o'clock, so it's anytime between 2 and 4.
So what time is good? What time is good for you guys? Because I'm a bit. I'll let you choose. I'm just a bit frustrated with what's happening.
I think 2 o'clock is fine.
So you prefer it at 2?
Yes. Is there something you'd like us to do?
Well, you guys should have prepared for the exam. You're supposed to just examine a patient, so I'll be there just observing while you guys do your examination, and then we go through what you did.
Okay, Doc.
So isn't that what Dr. Bailey told you?
Not exactly.
She says a clinical session is supposed to examine a patient on the ward.
Okay, so I
And
guess
that's what she told us, yes.
we'll just have to find the patient.
All right then. Okay, so I see you at 2 o'clock. The non-infectious ward is ward 15, so I think that's where we should start. Hopefully there's a patient there that is willing for us to examine them.
Okay, Doc.
All right, sorry about this. I just have to find another day to do this. All right then.